will now proceed with the keynote address, and it's my great pleasure and my great honor to introduce Dr. Scott Shikora to deliver the keynote address for the day's proceedings. Dr. Shikora went to medical school here in New York City at Columbia University. He then proceeded to a general surgery residency and a nutritional fellowship, both at the New England Deaconess Hospital up in Boston. Then spent 4 years in the U.S. Air Force. And then he joined the faculty of Tufts, again in Boston, rising to the rank of Chief of General Surgery. And several years ago, he moved across town from Tufts to the Brigham and Women's Hospital, and is currently the Chief of Bariatric Surgery there. He's a full professor at the Harvard Medical School. In the past, he's been the president of the American Society of Metabolic and Bariatric Surgeons. He's a great friend of Israel, has done a lot of work in terms of conferencing in Israel. And so it is my great pleasure to welcome Scott to deliver his lecture. And he's just an example of how you can be a nice guy and a great surgeon all rolled into one person. So, Scott.
Thank you very much for that very warm introduction. Yes, Ani Ohev Yisrael, and always will. In fact, I'm coming, I think, in October. And Elliot, I think I know you almost 30 years now. We've been in this field a long time. I want to thank the meeting and those who put this meeting together for inviting me. This is a great honor. And I hope my presentation is worthy of you inviting me. I really like this topic, and I like speaking about it because it's physiologic, and it also goes against a lot of the old teachings that we had when we were younger about how patients fail and why they don't all do well after surgery. And this talk basically, I think, balances out that it's maybe not the patient's fault, at least not all the time. So without any further ado, here are my disclosures, and none of them have any bearing on this presentation. For those of you who publish weight loss and bariatric papers, I am the editor-in-chief of Obesity Surgery. Well, I think it's fair to say that the current bariatric operations generally are good operations. Even the lowly band had some good results. However, despite a good operation, as you just saw one done in India, and choosing the right patient and going through all of the steps that we go through, all of the effort prior to surgery, we still see somewhere between 20 and maybe as much as 30% of patients will fail to maintain the meaningful weight loss that they achieved. In fact, during the pandemic, many patients who had been doing well came back with weight gain because of boredom and being in the house and unable to go anywhere, do anything. They couldn't work. I called it the pandemic 10, but actually even some people gained significantly more than 10% of their lost weight. So traditionally we blame the patient, but let's go into this a little deeper, because the human body is a very dynamic organ and it wants to maintain body weight at some set point. And as you can see, there are other factors involved in one's weight. This is the 10-year data from the Swedish obesity trial. And the reason I show it is that no matter which operation the patients had, over the course of years, they all put weight on. And that's exactly what we see. A lot of patients who come back with this slow progressive weight gain. Why is that? We're so careful in our selection up front. They meet with the psychologist, they meet with the dietitian, they meet with the surgeon, they meet with other people. They're all told about mindful eating and small amounts and healthy food. And yet we have a almost 30% failure rate. Now, I want to take one step back, first of all, because I don't believe we have a good definition for failure. Now, failure is becoming a bad word in this field, and we're using other terminology for people who have not done well, but bear with me for the sake of the small amount of room on a slide. I'm using the term failure to mean people who didn't live up to whatever the expectations were. But here's the problem. We have no standard definition for poor results. How do we define it? If we can't define it, we can't figure out how many people are affected and what to do about it. Should we go by the old 50% excess weight loss? I believe not. I think that's a terrible way to judge how successful a patient may or may not be, particularly in the realm where you get less significant weight loss with endoscopic procedures and with medications, but some patients do very well with that. They may not achieve a 50% excess weight loss, they may achieve a 30, but they improved health, well-being. How could that not be success? What about weight regain? What amount of regain is tolerable before you say somebody has failed? Lack of improved health, I would think that's probably a reasonable starting point. Lack of improved quality of life, ditto. I know it when I see it. I think everybody judges it differently. And then I question, should it be universal where you've got one set or one characteristic and you apply it to everybody? Or should there be separate and individual and unique characteristics for determining success versus failure for each operation or for each patient? I'm not a big band person, but I think if we came out in the beginning and said that success with the band would be an estimated 20% or 25% excess weight loss, the band may still be popular today. But by saying that we set the target at 50% is where we killed the band. And we would kill endoscopic surgery the same way. The difference being that a little bit more current is that you have people out there now actually saying, oh yeah, 20% excess weight loss is pretty good. My patients off their diabetes medications, sleep apnea has gotten better, et cetera. So we don't really have an answer for what determines who succeeds and who doesn't. And then it always comes back to the old saying, what came first, the chicken or the egg? Did the operation fail the patient? Or did the patient fail the operation? Or is it both? And I think it's both. We're all familiar with this. Weight loss is when you burn or take in less calories. You burn less calories than you eat. And weight gain is when you take in more calories than you burn. And this is what we're hoping for once we a year or so out from surgery, that the amount of calories consumed equal the amount of calories burned, and that will give you weight stability. And there are a lot of factors related to this from the surgery. First of all, we dramatically reduce hunger because of the manipulation of hormones such as ghrelin. The pouch capacity, we make a very small gastric pouch, whether it's a sleeve or a bypass or a SADI procedure, so patients can't eat like they did before. Early on, at least for the first year, there's eating intolerance, and many patients find that there are a lot of foods they can't tolerate, they can't swallow, they can't eat. And that also helps with maintaining the weight loss. And then there's just their behavior, what foods they choose and how often they eat, and do they try to snack or not snack. On the other side of the equation, generally in the beginning, we have increased activity as patients are motivated to do physical activity and exercise. We have an effect on resting energy expenditure, and lean body mass, as you'll see a little later on, is also important. The more lean body mass you have, the more calories you burn. Now, what do we know? We all know, every bariatric surgeon knows, that in the first year after surgery, for the reasons I just mentioned, patients take in very few calories and have dramatic weight loss. However, after the first year, the physiology starts to change. It starts to go the other direction. And at that point, patients find they can tolerate foods they couldn't eat before. They can eat more often. They can eat more food. Lo and behold, they take in more calories. Now, in this study, this shows a couple of interesting things. This was a study of 141 patients that had abandoned gastric bypass, the procedure you just watched. And they divided it up into three categories. The category that you would deem to have not done well, less than 50% excess weight loss, or in this case, excess BMI loss. Then you have the intermediate category, 50 to 75%, and then you have the ones that did well at a 75%. And what you could see here is that the energy expenditure for all three categories is the same. And the total energy intake was much less with the two successful categories compared with the one category that was not successful. And these numbers, because of the small series, are not significantly different. So basically, they were taking in as many calories as they were burning, whereas the successful groups were taking in less calories than they burned. Also, although it didn't reach statistical significance, was the fact that the group that didn't do well ate more fat than the groups that did well. Not surprising, this thing we all see all the time. Is it always the patient's fault? No, of course not. But let's not let the patient off the hook either. The patient may have had minimal preoperative education. Now that's changed dramatically with the Center of Excellence approach, where patients have to meet a multidisciplinary team. But I can tell you, in the bad old days of bariatric surgery, it was often just a surgeon and maybe a nurse, or a surgeon and maybe a dietitian, and that's all the patient got. So they never really learned the proper behavior or the proper dietary restrictions and changes that they need to make this successful. There was inadequate informed consent, where the surgeon may just say, you're going to lose a lot of weight because you can't eat very much, and didn't go over the explanation about what else it's going to take from the patient's end. We'll talk a little bit more about poorly chosen or poorly executed surgery, and also some of the alterations that can occur after surgery to the operation, even a good operation. And then there's the issue with lack of follow-up, and it's pretty obvious that patients who don't follow up with you in the clinic, don't come back and see you, generally don't do as well as those that do keep up and come to their appointments and are engaged in what goes on. So, etiologies of failure. I mentioned briefly that the surgeon may have not done the best operation, or may have done a good operation, but had very little infrastructure to engage the patient after surgery, or was offering operations that were not considered to be top-notch or good operations. There are issues with the patient, with compliance and follow-up. And then it could be neither, just the hormonal changes or disruption of the anatomy that then affects weight. We have lived through a number of operations that everybody said that we finally came up with the latest and the greatest, and it's going to get rid of the gastric bypass forever. And we're going to do bands on everybody, or we're going to do V-block on everybody, or we're going to do vertical band gastroplasties. And this is a small sampling of many different procedures that have come and gone over the years, generally gone because they didn't work. And there are many patients out there, and there's still some that have the old intestinal bypass. So a lot of operations were given to patients with good intent, but bad operations. And even a good operation can go awry, whether it was poorly constructed at the time of surgery or whether there was dilatation, we'll never know. But the middle X-ray is what a normal gastric bypass should look like: the gastric pouch, the anastomosis, and the rulum. Here is a gastrogastric fistula, where food can get into the big part of the stomach. Patient can eat more, and those that get ulcers eat more because it relieves some of the ulcer pain. And here is a great big dilated gastric pouch, and clearly that's not going to work real well to maintain weight loss. Same deal with the sleeve. What you can see here is a dramatic dilatation of the proximal part of the sleeve, and the studies have suggested that patients such as these will do poorly with weight loss and probably also have reflux problems. So even our beautiful sleeve operation over time can either dilate or may not have been well designed at the time of surgery. And again, let's not let the patient off the hook and blame the team and the surgeon for all of the issues. Patients are not always compliant with follow-up. They may have unrealistic expectations of their weight loss. They may have unrealistic expectations of their diet and thinking, well, I had a sleeve operation. I could eat whatever I want because I had a sleeve operation. I'm going to lose weight. Not so simple. And they develop maladaptive eating habits, grazing, carbs, favoring carbs, binge eating, or getting back to old habits such as getting up at midnight and going to the refrigerator. I love this quote from Barry Fisher because I think it sums it up completely. Half of my patients take half of their vitamins half the time. Just basically saying that compliance is a challenge. So what about that? This is a study that looked at 100 patients that had a Roux-en-Y bypass. The initial mean excess weight loss was about 59%. That's very good. But 56% of patients had weight regain. And I would suggest that that's probably a low number. It could even be higher. And the weight regain increases with time. The further out you get, if the patients are not back in the program and engaged in the activities of the program, will just slowly continue to creep their weight up year after year after year. And it often correlates with poor diet and sedentary lifestyle. The pandemic was the perfect example of this. And this is the data from their study. And I want to point out a couple of things. What you see here are the newbies, patients with less than 2 years after surgery, the intermediate group, 2 to 5 years, and this group were the guys and gals who are out over 5 years. And what you could see, if you just follow things, calorie intake went up, and the switching of the diet to more snacks and sweets went up statistically significantly. And that was the big change with it. That's here. Same thing for oily and fatty foods, and needless to say, almost 60% of patients had weight regain because of that change in their diet. Could not compliance be improved after the fact? David Sarwar is probably one of the top bariatric psychologists in the world and has written extensively about this and other topics. And his feeling was that self-monitoring of dietary intake and weight change is important. So the patient needs to know what they're doing. They need to weigh themselves. They need to write down on a diet recall sheet what they eat and go over it with a dietitian or a psychologist when they come in for their appointments. There needs to be something to offer the patients, whether it's support group meetings, individual meetings, something to keep them active, to keep them involved. We need to stress physical activity. And I always tell patients, walking is exercise, because they'll often say, I can't exercise, but I walk a little bit. Yeah, well, that's exercise. That's good. Keep it up. Walk a little more. You need to keep patients thinking about it. You need to keep patients working on it. And here are some of my thoughts about how to reduce compliance. I think sometimes in this day and age, we're not as careful with candidates as maybe we should be. And we may be picking some people that this just isn't the right way to go. And they just won't do well. When you have the right candidate, you need to educate them. They need to understand their operation. They need to understand very clearly what the diet needs to be after surgery. And they need to see a multidisciplinary team. I'm pretty good at nutrition, but I'm not a dietitian. At this point in my career, I think I'm pretty good as an amateur psychologist with these patients, but I'm not a psychologist. We have 2 in my program. They're much better than I am. They're PhD psychologists. Patients need to be involved with them because they have the expertise. We need to perform the operation correctly. And even in teaching institutes, the operation should be performed as well as possible under the supervision of the bariatric attending. And again, keep your patient involved with activities in the group. We'll talk a little bit more about medications, and you'll have a talk about that coming up. And now with virtual visits, there's no excuse not to be able to interact with patients. It is so easy to do a Zoom with a patient or even a telephone visit. I do a lot of it. I enjoy it. I have a lot of fun because I see them. I don't know why, but I go into these virtual clinic visits with just more enthusiasm than seeing somebody in the office. But that's a great tool. You can do educational programs with your patients. You could have support group meetings. There's so much you can do if you put your mind to it. However, despite all that, we do know that pouches over time do stretch, they get bigger. The small bowel accommodates. So if you make long limbs and you think that that's going to be the answer, some patients over time, the bowel adapts and they absorb more calories again, and they have weight issues. Dumping syndrome, some people call a complication, other people call an attribute of the gastric bypass. It clearly, for the first year or so, prevents patients from eating carbs, but a lot of patients with gastric bypass, after a year or two, the dumping syndrome becomes much more mild, and now they can really eat carbs and candies and things that they shouldn't be eating because they can. And some of them will have a return of appetite. And some of the foods they couldn't eat before, like pizza, like pasta, like rice, now they can. And that becomes a problem. And of course, the world they live in, the societal and cultural pressures remain. So whatever drove them in the first place to bad eating habits, those problems may still be in the patient's lives. Now, we have to also bear in mind that patients take medications for other reasons, like depression. And what you see here is a partial list of medications that are known to promote hunger and weight gain, particularly the antidepressants. So if you have a patient on these medications, you may be spinning your wheels trying to get them to lose weight. The question is, can they be switched from an antidepressant, for instance, that promotes weight gain to one that doesn't? And that certainly could be of help. And this is what happens here. Hunger goes up, pouch capacity increases, eating intolerance decreases, behavior decreases. They become less motivated, less careful. A lot of them will say, I twisted an ankle, I stopped exercising, or I had a family emergency and I stopped exercising, and then it's hard for them to go back to it. So they're burning less calories. Their resting energy expenditures go down with the weight loss. So it's easy for them to put calories back on. And with less lean body mass, they're burning less calories as well. Now, body weight is aggressively defended like a thermostat controls the temperature in your room. So for instance, in my house right now, I presume the thermostat set at about 70 degrees, and it's 70 degrees whether it's 20 degrees outside or whether it's 100 degrees outside, Fahrenheit, of course. And this is it. And this is a very interesting graph that I like to show. So this is an animal study, a rat study, and there was an obese group in red. There's the thin group, and we'll talk about that in a minute, in yellow. And then there's the average group and a control group in green. And what this study did was it created a group of basically fat rats and skinny rats. And let's start with the fat rats. They were given excessive amounts of food forcibly to get them to gain weight. And then at some point, they were no longer force-fed and allowed to eat as they wished. And look what happened. They dropped their food intake and their body weight dropped until it got back to baseline. Here's the skinny group. They were underfed to become essentially malnourished. And then at that same point, they were put on ad lib. They could eat whatever they wanted, and they put weight on and got right back to the midline. So what you're seeing here, in my opinion, is that the body is regulating body weight on its own, and that it's setting it for whatever the set point is, in this case, somewhere around the 300 grams. And there are a number of other factors involved, dietary intake, exercise, metabolism, and depression, medications. As I've mentioned already, all of them have an effect, have a role. And there's other factors as well, satiety and satiation cues, such as social content, homeostatic mechanisms, as I just showed you, habits, learned behaviors, cognitive factors, and all of this. Appetite, satiety, and hunger are very, very complex metabolic pathways. And as you could see, and I'm not going to dwell on this, that there's a lot of battling between inhibiting and stimulating that the body does to maintain body weight. So if you lose a lot of weight, this process shifts into weight gain mode, and making it difficult for the patient to fight off hunger. And the opposite's true as well in many cases. If patients put a lot of weight on, this thing will downregulate. And it involves quite a number of hormones. So when you have weight loss from surgery, they all drop except for ghrelin, which goes up, except in the setting of the sleeve where we resected. But this influences what body weight is. And the other thing that's involved with this is the vagus nerve. And this is how it seemed to all divide up in the different areas of the body, the adipocyte, the pancreas, the stomach, and the intestines. A lot of hormones involved, a lot going on in the body with weight loss from surgery. And this is what you see here is preoperatively, ghrelin was almost 600 in pre-op gastric bypass patients. And at 3 months after surgery, it started to go up. And by 12 months, it was quite high because the patient had lost a lot of weight that stimulated the ghrelin. The sleeve is a little different because you resect so much of the fundus, you resect a lot of the ghrelin producing tissue, but ghrelin is still produced in the sleeve, and it's produced in certain parts of the small intestine. So even the patient who's had the sleeve, ghrelin doesn't go down to 0 or to extremely low numbers. Now, after surgery, patients lose fat, but they also lose lean body mass. And lean body mass has a role in resting metabolic rate. Think of it this way. The lean body mass is an engine of a car. And when you have a lot of lean body mass, you burn a lot of calories. That's like the 8-cylinder engine that gets very poor gas mileage because it's such a big engine. It's very hungry. It soaks up a lot of gasoline, which in this case is the calories. What about the small car with the 4-cylinder engine that gets very good gas mileage? Well, it doesn't burn up much gas. And that's what happens after bariatric surgery. Patients lose lean body mass, energy expenditure drops, they burn less calories, they burn up less gasoline in their engines. And this is data from my own program and when I was at Tufts. And this looked at a group of patients that had, believe it or not, open gastric bypass many, many years ago. And we measured their energy expenditure and body compositions at baseline before surgery, follow-up, and then looked for any change. And what you can see here is no surprise, body weight drops, fat drops, the fat mass drops. But look at total energy expenditure. It dropped as well, and resting energy expenditure, because you had less cylinders, so to speak, that dropped. So the patient's metabolic rates came down after bariatric surgery, kind of like what you see in a starvation mode. And that now the patient has to exercise more to burn the calories they were burning before they had surgery or shortly after surgery. So you lose muscle mass along with fat, that you decrease energy expenditure from physical activity because you are no longer physically active, and that decreases the total energy expenditure. Boom, weight gain. So just in my last few minutes, I'll just briefly touch upon some of the options for patients who have weight regain, and you're going to hear more about it later. Dietary and lifestyle change is always the right place to start, but unfortunately, be honest, doesn't always work. Commercial diet programs, same thing. You may get some bang for the buck. It's generally not sustainable, but there's no harm in trying. Pharmacology, I think, is getting better and better. We have more options now. We have better medications, and some of them work very nicely in post-operative patients. I personally think, and this is an aside, that down the road, we are going to be sending patients home from the hospital after surgery on a medication for weight. And the two of them are going to be synergistic, and we're going to start that when they go home. We're also seeing the development of an endoscopic array of procedures that can be performed for revisional surgery on patients with weight regain. And then, of course, there's revisional or conversional surgery. As far as medical evaluation and initial therapy, there's no rush. the patient didn't gain all that weight in one day, they don't need to lose it in one day. Consider it's going to take 6 to 12 months to really know whether there's any benefit to what you're doing. Screen for depression because of the meds for depression that increase appetite. Evaluate other medications for the same thing, not just the depressive medicines. Emphasize realistic outcomes for the patient. Don't tell them they're going to get down and lose 100% of their excess body weight. Be realistic with them on what you really expect, particularly once they've regained weight. And then you can try the commercial diets, the liquid meal replacements, fasting, and even the medications. And when earlier on, when we started using medications, phentermine was really the only game in town. It was called Fen-Phen. It was a combination of two meds. But as you can see, we have more choices now. Some of these are injectable. The problem in the United States is some of these are not covered by health insurance and quite expensive, but they do seem to work fairly well in patients that have had bariatric surgery. As far as the sleeve, I'm not a big fan of re-sleeving the sleeve. I think if the sleeve became ginormous, there's a role for it, and it may be good. On the other hand, if the sleeve is just enlarged and you take a sliver of it off, I don't see any benefit. We're seeing better results with endoscopic plications and endoscopic narrowing of anastomoses, but a lot of the studies are still small number of patients. They're not randomized, and there's not a lot of long-term follow-up. And this is just one paper on re-sleeving. Now, granted, those who get better results are going to be more prone to publish their results than those who don't get good results. But in this study by Philip, they took a group of patients that had less than 50% excess weight loss, meaning a lot of them gained weight back, and they were able to successfully re-sleeve. And to be honest, it's a pretty easy procedure. And they ended up with a pretty dramatic improvement in weight loss, almost unbelievable, but that's what they published with a mean of 3-year follow-up. You can convert a sleeve to a bypass. You just saw one. In this study, 11 of the 89 patients were done for weight gain. Most of the other patients were revised for complications of the sleeve, like severe GERD. The bottom line is those that were revised for weight gain did fairly well, and I think that that's pretty consistent. You can convert a sleeve to a SADI-1. It's basically set up for you to do so. The sleeve was the first part of a duodenal switch historically. So this is basically what you're doing here is essentially a two-step operation to get you to a one anastomosis duodenal switch. And relatively good complication rate, excellent weight loss. The BMI units dropped by almost 10. That's pretty impressive, and diabetic remission in almost 100% of patients. Now, if you still have patients out there that have a band, which at this point is not many, you could remove the band, convert them to a sleeve. Some people would say you don't go from one restrictive procedure to another. You go to a malabsorptive like the bypass or the duodenal switch. Some people will even leave the band in place and create a gastric bypass below the band. So it would be essentially similar to what you just saw live. Having tried that once, I wasn't very impressed with the result. You could convert a band to a bypass, and that's been very popular. This was one of my fellows, and we demonstrated that we were able to get decent weight loss after we converted patients from sleeves to bypass. What about the gastric bypass? You have less options than the sleeve for what you could do to create a better situation. There's not a lot of harm into at least attempting endoscopic plication or outlet reduction because it's very low risk. It's done endoscopically. And if you don't succeed that way, you can still go to surgery. You can revise the bypass. I'm not a big fan of redoing the entire operation. The leak rate's quite high, and reoperative surgery, as you know, is more complicated than the original procedure. I'll mention a few words about limb discalization in a minute. The endoscopic revision, we're seeing more and more papers now Still, a lot of the papers have short follow-up, not a lot of long-term data. This study had only 6-month follow-up on 96 patients, so about 90% of patients, they did have follow-up. They were able to demonstrate that they made the pouch and outlet smaller, and they were able to get some weight loss from that. Question, what happens a couple of years down the road? Did these dilate again? Do the patients put weight back on? And we don't have those answers. Another paper on endoscopic revisional surgery, 55 patients, 41 of them had revision of the pouch and stoma, 2-year follow-up, so not a lot of follow-up. And they had only 19 patients when they wrote the paper, but the 19 patients had a 29% excess weight loss. So once again, interesting. We don't have all the data to conclusively say this is the way to go. What about surgery? Well, just off the bat, any revisional surgery, as any bariatric surgeon knows, carries 3 to 4 times the risk of the first operation because of these factors, particularly ischemia, adhesions, and the fact that the anatomy has been altered. And sometimes it's not so easy to understand the old anatomy. Going in and pouch trimming, once like the sleeve, I would only go in and trim the pouch if it looked ginormous, quite large. If it looked just dilated like many do over time, I don't think that I would take that patient to surgery to pouch trim because I'm not sure it's going to add anything to it. This one study of only 5 patients, they had 2 complications, a perforation and a stricture, but they did achieve a reduction of the BMI from 43 to 28. So successful in a few number of patients with relatively short follow-up. What about making the anastomosis narrow? This study looked at that in 44 patients and found, once again, short follow-up, about 2 years, but we're able to demonstrate that there was some benefit to doing it. Once again, I would wonder at 4 and 5 years, how do these patients fare? And here's the kicker. When you read articles, look to see what follow-up is, because if you have only a third follow-up, the other 2/3 may be doing very poorly, and that would totally skew the data. So you look at this and you keep that critical eye on it, that even though they got results, it was only for a third of the patients. How did they select the third? Were those the ones that happened to come back? And those that come back happen to be the ones who do better than those who don't come back, which is also true. So you got to be careful. Limb dislocation. Limb dislocation is where you take a gastric bypass, such as this, and you manipulate the limb lengths. You either lengthen or shorten them based on your philosophy of which one's more important. And there's quite a bit of literature now suggesting that the biliopancreatic limb may be the more important one hormonally and for weight loss. In any event, you disconnect the gastrogeg, the enteroneurostomy, and you plug it in further distal. And what you're doing is shortening the common channel. How much to do it is not known. Which patient would be better with this is still not known as well. I really was enthusiastic about this, and this is some of my data. We have a few more than 22, and I want to go over my data, and then I want to let you know that I've become somewhat more disappointed with this because we did great with patients for the first few years. Everything looked wonderful. I really thought we had a winner here for a very straightforward, very safe revisional procedure for gastric bypass, because usually very few adhesions, and all you're doing is moving the bowel connection. But as time went by, we've had patients that were doing great, all of a sudden stopped taking their vitamins. And with this procedure, you really have to stay on top of that because they're prone to vitamin deficiencies and protein malnutrition. And we've dealt with having to place them on TBN. We had to reverse some of them. So I'm right now currently a little disappointed in something I had a lot of high hopes for. But in our first 22 patients, we did have 3 develop protein malnutrition, and we made the common channel a bit longer after we noticed that, and vitamin deficiencies. 2 of them we were able to rescue on TPN and then feed normally. And I tell them up front, particularly in the beginning, and also depending on what you eat, you're going to have a number of bowel movements a day. Are you going to be okay with that? And they know that. everybody in my program who talks to these patients tells them about the importance of eating right and of taking their vitamins, and it still doesn't sink in. Half my patients take half their vitamins half the time. And this just goes to show you that it is extremely effective for rescuing patients with weight regain. So in conclusion, while anatomic derangements and patient compliance can result in weight regain after bariatric surgery, the human body is also programmed to return to a preoperative weight. And the analogy I used was the house thermostat. Good candidates, people that you really, really felt were winners, can and will fail very good operations. Understanding these physiologic processes should enable the programs to create better options for long-term success. And as I was saying, my hunch is that someday, like we do with heart surgery or we do with other types of surgery where we send patients home on medication, we will be sending our patients home on something along with their operation to help them maintain their weight loss. And once again, I want to say toda rava to Elliot, to my other friends who are listening to this, and to thank you again for allowing me to speak. Thank you.
Great. Thank you very, very much, Scott. Fantastic. So there was one question from the chat in terms of preoperative workup and diet restriction. You mentioned the idea that in the same way as one perhaps should tailor the definition of success and failure for each particular surgical procedure, what about tailoring the preoperative weight reduction and preoperative diets for each particular surgical procedure? So rather than having a sort of universally applicable pre-op protocol, perhaps dictated by insurance requirements, do you think that each particular operation should have its own pre-op dietary sort of manipulation?
I do, to at least a degree. I think there are commonality amongst all the operations that would be well managed by one standard approach. But I agree with you 100%. The other half of the approach may need to be tailored to the operation, and maybe we need to be telling sleeve patients a different story than we're telling bypass patients. And maybe we need to be following them differently. We did that for a while with the band because we were having the band patients come in every couple of weeks for an adjustment. So that clearly was a different way of treating them than the patient with the gastric bypass. And those were things discussed preoperatively with the patient, that you have to come in and get your band filled or else it doesn't work. So I agree 100%. There may be a time where we either look at operation or patient type and determine our preoperative evaluation and preparation based on that information and not have a one size fits all.
Right, excellent. I have my own question. We talked a little bit with Mohit about bougie size, sleeve size in terms of weight loss and weight regain. What's your thought in terms of the optimal sleeve size? Whether you think that if you make the sleeve too big, that will set up the patient for significant weight regain?
I agree with you 100%. And the converse is true. If you make the sleeve too narrow, you're more at risk of strictures and leaks. I don't think we know what the appropriate size bougie is. And I think it may be different from one patient to the next because of different physiology or different anatomy. There may be one with a larger stomach than another. The other issue with the bougie is, do you really jam it against a lesser curve and staple really tightly, which means you're going to end up with a smaller sleeve than if you have the bougie, the same size bougie, resting comfortably along the lesser curve and you come up comfortably with the stapler, you're likely to have a bigger sleeve. And there's data to suggest that sleeve size is not the whole story about success and failure. So if it's a little bit bigger or a little bit smaller, it probably isn't that relevant to outcome. It's probably more behavioral at this point and other factors. So I don't think we know any of those answers. I would use a 38 to 40 French bougie. I would put it comfortably along the lesser curve, and I would staple it comfortably, leaving just a little bit of extra stomach because I didn't want a stricture or a twist. And whether that affected weight loss, hard to say. This hasn't been studied in any really good randomized fashions to my knowledge.
Elliot, I have a question also.
Sure.
Yeah. Scott, thank you very much for your lectures. As always, brilliant lecture. I had privilege to attend your talks a couple of times here in Israel. Look, I'm not a bariatric surgeon. I'm HBP and surgical oncologist, but as a head of department, I have some exposure to bariatric surgery. And I'm following what's happened, at least in my country here in Israel, during the last 35, 40 years. Bariatric surgeons, they change their mind a couple of times, they start SRVG, SVG, then sleeve gastrectomy, and then they switch, to omega gastric bypass. When you are judging what's going on in the world, there is huge difference between countries and between institutions. What is the popular procedure for metabolic patients, let's say. My first question, why it's happened, and what do you think? What is the next very practical step? What's going to happen next 50, 20 years?
50, 20 years. First of all, I think that we're going to be shifting from laparoscopic and not even robotic surgery. I'm going to call it computerized surgery, where we put ports in and then we put into the computer some code, and it's going to then do the entire operation with us only sitting there watching it. And it's going to do all the cutting and sewing, and everything will be mapped out by the computer before it starts. So it's going to know exactly where everything is. And I have a feeling in 30 to 50 years, all surgery is going to be done that way. I don't see why not. In bariatric surgery, I think the issue is going to be multimodal treatment, where, like I've been saying, patients will be on medication and have surgery, and maybe have an endoscopic tightening of the procedure every so often. We do see it in other areas of surgery. We don't see a lot of surgery where it's one operation, the patient's cured, particularly in cancer surgery. You're going to have reasons to need to go back. Cardiac surgery, vascular surgery, the same way. And meanwhile, we're looking at bariatric surgery and saying, if you don't get the good result with one operation, it's a failure. And it shouldn't be, because other diseases take more than one treatment, and it may very well be the same here, where you can get 5 years out of a gastric bypass, and then you need to do something else.
I have one additional question also in order to underline my first question. I was trained in Canada in HBP, and I remember the bariatric surgery guys and fellows. The most popular procedure 10, 15 years ago was Roux-en-Y gastric bypass. On the other hand, in Israel, most popular procedure was sleeve gastrectomy. When you're comparing two populations, they are both of them, they are Western population, and I don't think there is huge difference between Israeli and American population. Why it's happened?
I agree with you 100%. I think some of it's the leaders in the bariatric communities of the two countries enthusiastically supporting their procedure. The sleeve's a good operation. It's a great operation for patients that you want to get to lose some weight. You want to help them with their diabetes. It has its problems, such as GERD. And it's the most popular operation in the United States right now. It's about 75%. So we're not that different than Israel. I really think that the pendulum with the sleeve popularity is going to shift back some to the Roux again, because I think overall the Roux is a better operation, but it does carry more risk, and patients don't like the sound of it. I don't want you rerouting my plumbing doctor. They would much rather just have their stomach made smaller. But I think more and more sleeves are going to come forward and need revisional surgery, and it's likely going to be a Roux, because a lot of them it's going to be for severe GERD or esophagitis. But it's like everything else. It's the flavor of the month. One gets popular, and you get a couple of prominent surgeons behind it. And Phil Shower really pushed the sleeve in the United States during his presidency of ASMBS, and we all respect Phil highly. And I think that really helped tip the scales over in favor of the sleeve gastrectomy. Was his enthusiasm. Same thing, Raul Rosenthal. Same thing, Michel Gagne.
So two more questions before we take a break.
Okay.
Dr. Jallo asked whether, or what your opinion was of Botox, endoscopic Botox injections into the stomach. And I had a question, in the same way as you look at different parts of the world in cancer outcomes, let's say gastric cancer, doing gastrectomy for cancer tend to get better results in Japan than you do in the United States because of earlier presentation or better screening in Japan for gastric cancer than the US. So my question would be, do you see any differences globally in terms of patterns of obesity, patterns of obesity surgery, and outcomes from one country to the other?
That's a great question. And yes, if you look at the Asian population, including Indians, Pakistanis, Chinese, Koreans, etc., their weight distribution is different than a Caucasian or an African in that they have more belly fat than they do peripheral fat, which is the unhealthy fat, of course, the metabolically unhealthy fat. So they're going to get the complications of obesity, the metabolic syndrome, et cetera, at lower body weight and lower BMIs than us, let's say, Caucasians. So in the United States, we're greatly prejudiced against that population. Our insurance companies are, because we're using the same cutoffs, the BMI 35 and BMI 40, to see who's qualifies for surgery. But an Asian with a BMI of 27 or 28 may have metabolic syndrome. The other issue along those lines is that patients, let's say from India, since you saw an Indian operation, many of them are vegetarians. They do not eat meat, and they become tremendously difficult to manage, or could be, with vitamins and also a protein intake. And one of my concerns is a popular operation in India right now is the one anastomosis gastric bypass with a 200 centimeter afferent limb. I think the patient who doesn't eat meat is, and by the way, the paper about meat eaters came out of Israel many years ago. The non-meat eater is going to have much more difficulty with vitamin deficiencies and protein malnutrition than the meat eater. So yeah, that's a part of the world where that operation probably is not the best choice.
And the comment or the question about Botox injection.
Eliot, before he's going, I want to add some very important point. When you are talking regarding difference of outcome between countries, the main point in this difference is also education of population. What is going on after surgery?
And culture, by the way.
Yes.
I remember doing an insurance denial. I used to help out by overturning them in patients that were denied. And there was a woman from California who was of Mexican heritage, and she wanted a duodenal switch, and the insurance would only want to give her a gastric bypass. And she said, if I have a gastric bypass, I can't eat the foods that my family eats at holidays, which is rice and beans and all that. She said, you're basically taking me out of my family by making me have a bypass. Give me the duodenal switch, at least I can eat those foods. So yeah, there are differences.
Right. Okay, last, Botox.
I've used Botox after a reversal of a gastric bypass, because sometimes the pylorus becomes stenotic and the stomach doesn't empty. The literature on Botox is a weight loss procedure. It's pretty harmless, but it probably doesn't really do a hell of a lot. And maybe you want to do it to get some weight off a patient, to then think of step B, whether it's surgical or endoscopic, but I don't think Botox is the answer to our problems. Right, I tend to agree. Great. Thank you very, very much, Scott. That was fantastic. Very